Thank you. I actually, Dr. Wang, you and I also met in such, how can I help situations, and that is still continuing. And I think that's one saving grace for humanity. We're adaptable, and we come together as a tribe, hopefully beyond political and scientific boundaries.
Absolutely. I mean, reaching out to you and with all the assistance that you provide and the network, the support, it's no longer about an industry or a vendor. It's actually about relationships, and everybody can actually help. And in these settings, who you know and the friendships that you've built means so much to every single health system.
Yeah, same here. I mean, I've received so much back as well, and you three are in my cadre of heroes, by the way. So, and we'll talk about why maybe a little bit later. Dr. Prasad, any stories from North London?
Yeah, so I think two things have really stood out. One has been the community collaborative spirit, and by community I mean the general population. The way they have observed lockdown was incredible, and the way that the community, the scientific community, has got around, come together globally within London to focus on one problem. Egos have been put aside with the greater good in mind, and there's been a lot of multidisciplinary, highly innovative thinking about how we can tackle this problem, and that's what it's going to take for something of this issue. So I think that's been really inspiring to see, and I really hope that it engenders an ongoing collaboration that's highly multidisciplinary and that's highly focused around problems working together. I think the other thing that's been really impressive is how 20 years of planning for changes in the way that care is delivered to patients has suddenly happened within 3 days. And a very simple example is that all of our outpatient clinic appointments, which have always been face-to-face, within 3 days suddenly converted to by phone, and will soon become a digitized video calling facility with a digital waiting room. Things that would have required months and months, years, dare I say, of planning and issues of confidentiality and infrastructure happen within 3 days. And the feedback from patients has been amazing. And for many of them, particularly the ones that are well, it's been a great change. But more beyond that has been the opportunity for access, where historically there was always a cohort of patients that for a number of reasons always found it difficult to come to clinic, whether that's economic or that's due to their debilities. And suddenly they are very much in the service from their living room. And that change to patient-centric care, I think, has been really inspiring.
Thank you. Dr. Swante Pabo, who is a famous evolutionary biologist, wrote a very good book called The Neanderthal Man. He actually spends 2 chapters in that book just on RNA quality and how do you decontaminate the room, how do you put positive air pressure. We're actually learning if you have to do testing at scale, it is quite a challenge, and quality is not to be joked with. When I learned about statistics, we talked about confusion matrices, false positives and false negatives, and yeah. So, Dr. Wang, thoughts?
I think what I learned this past week is something that I've been learning and relearning every single day and getting reinforced, and that you're not alone. And you're not alone as a human, you're not alone as a clinician, you're not alone as a scientist, you're not alone as a go-doer. And my best example would be you, Sanjay, and bring everybody together. Everybody, when they are quarantined or when they're reading the media, reading the news every day, it can be really stressful and information overload. If you take a step back and open your eyes and actually allow yourself to see that people are fighting and that you have to find your friend and actually form the alliance, there are a lot of good people out there making a lot of progress, and that doesn't make good clickbait news. But
thank you for saying that.
It's not as attractive as other headlines, I would have to say, but there are amazingly talented individuals who are putting together groups, organizations, collaboratively, even here, but elsewhere too, and that you have to find them. And reinventing the wheel is not necessary in this pandemic. And I think every week I open my eyes up and I'm reassured in seeing that. And it brings a lot of faith into this pandemic and a lot of hope. And I think that's why we've actually come so far with our recovery numbers too. At our hospital, we're over 80% back to normal functioning now. And our procedure volumes are over 80% back to outpatient electives, which is pretty incredible considering we were at 100% ICU capacity and converted every outpatient PACU to a ICU bed too, and speaks volumes. But knowing that a cardiologist can reach out to a IT specialist and a machine learning expert and learn IgG, IgM immunology and try to speak the trade and try to just kind of go with the flow, it's been a fun ride. I'm ready for it to be over though.
No, I think there's been a lot of change. I mean, we are fundamentally a genomics institute. Testing COVID is not difficult, but it's not, the usual thing that we do. So yes, we are trying to figure out the host viral interactions, trying to build the relevant data sets, so we can try to understand who does better, who does worse. My normal day life of lung physiology and figuring out, poor lung function in, young people, adolescents, and adults. These days is backstage. Now I think we are more interested in finding out temporarily how can we use all this information to predict who requires more care, who requires less care, and make better decisions. So yeah, bit of a change these days.
I think pollution and asthma and eosinophilia has been also implicated, which creates some interesting connotations for folks in Detroit as well as in Delhi. Yeah, great.
Surprisingly, the risk factors.
So any stories that... Go ahead, please, yeah. Dr. Agrawal, please finish your thought.
Well, yeah, I mean, surprisingly, structural lung disease has not actually been as much of a risk factor as one would have imagined it to be. For a primarily lung-related bad outcomes, you would imagine that people with COPD, people with severe asthma would be dropping like flies, in fact, CF. So experience is pretty much coming that while it is a pneumonia, the structural lung conditions do not seem to be having much excess risk. I mean, it's moderate. Adjusted, you can say asthma is about maybe 20% extra, which is nothing compared to, say, hypertension or diabetes or heart disease. COPD is barely double. So yeah, there's something different about this compared to usual pneumonia mortality, where people with COPD and severe asthma tend to do much, much worse. That's very surprising, actually.
Thank you. I've read at length about the nightingales and normal folks stepping up. I know London has a famous history of the common man stepping up and doing things. Thank you again. So what do you, again, I just want to get to day right now. What are you seeing out there on a daily basis? What has changed in the last week, in the last month? As practicing cardiologists, Dr. Wang and Dr. Prasad, you still see patients on a daily basis. And again, Dr. Agrawal, you're probably getting back more into the clinical realm. You are a physician by training. Let's start with you. What are you seeing on a daily basis? I know India is on an uptick right now, probably exponential through probably mid-July.
Yeah.
What are you
so
seeing
right
out
now,
there?
I think India is clearly on the upswing right now. Mumbai, for example, seems to have peaked already. Delhi will be peaking very soon now. So we are seeing, pretty much for all mega cities at the peak too, the health structure getting slammed. And basically right now, the entire emphasis is on how to create more health infrastructure. So they're working on trying to create 10,000 beds. Most of the meetings I'm attending are with projection meetings. What will we need? What is the, some of the best indicators of where things are moving is your % positivity on your samples. So as your testing labs are telling you the positivity is rising to almost 40–50% of the samples you're receiving, the peak is near. And again, by looking at the data, the Arogya Setu app the government has built, big teams have been put around all this. As Sanjay was saying, I mean, digital has become suddenly the way to go. Doctors in India have resisted it for quite a bit because we have a very, small practitioner-centric system providing most of the care, not a large organized system. But pretty much everything has come together. Right now, most days are spent figuring out where is the next patient going to go to. And we keep making decisions and we keep changing them, I guess. At some point, we thought that, why are people being allowed to stay at home? They're infecting more people. And then you do a quick calculation, another group does it, they say, well, if we wanted to bring them in, we don't have the number of beds required to bring them in. So one day you're moving them, one day you're sending them back. So these confusions happen. I think they are natural, part for the course. But by and large, right now everything is about health infrastructure, getting enough number of oxygen beds. We have had some very, very interesting experiences in Mumbai, where the National Stadium was converted to a housing place. 1,200 people admitted, only one died. Pretty much showed, and this is in Dharavi, right? I mean, Dharavi is a
Yep.
major slum in
Yep.
Mumbai.
I used to live in Mumbai. So-
Oh, okay. So you know this. I mean, when Dharavi went up, everybody was like, oh my God. But I think the management of Dharavi will be one of the biggest success stories around the world, because you basically took a slum with lakhs of people living in it, took a disease like COVID and came out with almost minimal mortality. And the essence of it was what we learned from the US and UK to some degree. Start oxygen early, get the anticoagulation in place, check for D-dimers if you can, and pretty much intervene early. If you wait too late, they will die. So the focus of India has been on oxygen, getting them in, checking their SATs, getting at least an aspirin started, while you get them into a situation where low molecular weight heparin can be done the minute their SATs go low. I know the evidence is weak. I'm not, in fact, two better people than me can comment on it, but it seems to have worked in Dharavi.
Thank you. Yeah, my first telemedicine project was at Seattle Children's Hospital in the mid-90s, by the way. And my little story is that the technology has always been there. I think the major issue was payment. Somebody's got to shoulder the burden, and licensure. So is the patient coming across either state or county boundaries and getting treated, or is the physician crossing state boundaries or international boundaries at some point? I'm sure this is going to be a complete ground shift in how healthcare happens. Every disease is probably going to become a population disease, which is not a bad thing. I mean, I would say that, everybody talks about precision medicine. I would say we need to kind of move into precision population medicine. So I think there's a lot of change going on by fiat formed by a pretty interesting virus. Dr. Prasad, any thoughts?
Yeah, so I think what's been interesting over the last few months has been the shift. So your question was, how have things evolved? And thankfully, after March and April, which was super busy, things have quietened down. So we have now restarted in the last 2 weeks elective cases again. But our way of working has completely changed. So we're down to about 30% of capacity as we try and make sure that we reduce contact between patients, make sure that we're protecting the staff. So a lot of changes on that front to try and accommodate. And we're expecting that this is not going to evolve and really change till about September, October.
And most countries are anticipating at least another wave, probably several more. So
yeah, I think our thinking is that there's probably going to be splutters. We're hoping that London and other big cities won't need to go into lockdown again, but there will be, exactly as Dee Dee said, ebbs that can be better contained. And I think the key will be early recognition, early detection. And I guess a point that all of us have made has been, what's interesting here has been the variation in how different countries have approached this. And given that there was a wave of how the virus spread across the world, it's been interesting seeing different responses, some scientifically based, some economically based, and some based on just hunch. But I think there's real opportunity in preparing for the next big epidemic, whenever that occurs, in planning more robustly, collectively.
And Imperial has some experience in doing some of these things way back when. So let's stay with you, Dr. Prasad. What have you learned in the last week that you didn't know 4 months ago?
So I guess one of them has been about the effectiveness of certain medications. One has been an Imperial College trial led by Robin Shatter, which is now trialing a new form of vaccine, which will be interesting to see where that goes. No one knows whether it's going to be successful or not. It's early days. I mentioned earlier the fact that COVID could be unmasking diabetes was a particularly interesting point. I think there's been, if we focus purely on what's been really new in the last few days, I think that's been interesting. But I think a lot of unaddressed questions also remain.
Dr. Agrawal, maybe the soapbox for you in terms of what you've learned, and we've had some discussions on testing quality. Maybe some thoughts on that.
I think what I've learned last week is there's nothing called the perfect test. I mean, I knew that to some degree earlier, but it's been really hammered in the last week or so. When we realized that we got some, we didn't like some kits, so we got the best kits possible, which are, high fidelity all the way up to CTs of 38 or 39. All that happened to us was that we ended up with not knowing what to do with the data, because we are pretty much calling every sample positive. So you learn that, in crowded environments with sample collections, trace contamination is going to occur. For every problem, there is an optimum tool. Trying to raise sensitivity beyond that gives you problems. It's something looking back I should have known was obvious. But I mean, we have been trying so many things to improve the diagnostics. There is so much quality issues going on right now. Context must never be forgotten when you're doing science. And I think as a scientific institution, jumping head into a clinical decision-making system, that was a good lesson in the last week or so. Many things look wonderful in theory, but when you look at the reality of clinical practice, which is dirty, and I should have known that better, where you know that hundreds of people will be crowding up and samples are going to be collected, there is an optimal performance yardstick given the limitations of the system. So I think I've been learning in the last week how to balance all these things.